Hi everyone, so we're back. This is chapter 11, Barbara Garcia, and this is pathophysiology. So remember that page that I told you about in chapter 10 that you absolutely have to go back to and really know? That was back in chapter 9, at the very beginning of chapter 9. That is your figure 9.2, which basically is showing the pathways of cell differentiation in their bone marrow. Definitely want to know that because that's really going to set you up for understanding these disorders, the leukemias and the lymphomas of white blood cells. Okay, so leukemia, lymphoma, and plasma cell myeloma, which also called multiple myeloma, are neoplastic disorders, which are basically cancers of the bone marrow, right, and lymphoid tissues. So leukemias are usually circulating throughout the blood and maybe even, from that cell in the bone marrow, but the lymphoma is usually localized in lymph tissues. Sometimes it could be disseminated in other sites if the cancer has spread. Plasma cell myeloma, right, a malignant transformation of the B cell, plasma cells, and then you might see this one localized in bony structures. All right, so some of the typical signs and symptoms are malaise, weakness, right, fevers, especially nighttime and night sweats, recurrent infections, because I want you to remember that even though you may have an exorbitant amount of a particular white blood cell, that doesn't actually mean that the white cell is functional. Remember that in cancer cells, the cancer cells are not necessarily able to function at or for the function that they were intended for. So some of them may be functional, but not all of them. So actually they're not doing the job that they're supposed to do. Right? So you might have like acute lymphocytic leukemia, which, by the way, ALL is very common among children. It has about a 95 to 98% survival rate. That one you might see, obviously, lymphocytic, right? So you're going to have lots of lymphocytes, but that does not necessarily mean that those lymphocytes are doing the job of their specific immunity job. So children will recur and have lots of recurring infections because of that. So one of the things you might see is nodular lymph nodes, especially the ones that are palpable, which means you can touch them, right? Like in the neck, in the armpits, and around the breasts, right? Those, and in the groin area as well. Those you might feel a bump, but if it is not painful, that is a reason to be concerned and definitely go to a doctor. Now, if in your, for example, neck, you have swollen lymph nodes, and when you touch them, it hurts, that just means that the lymph nodes are doing their job. They have a job. They're trying to kill an infection. So don't you worry about it. That means they're doing a job. I mean, if it persists, definitely want to see a doctor. But in the short term, obviously they're doing their job of killing that infection, right? So, and especially with the lymphomas and leukemias, you're going to see this lymphadenopathy, right? Also, you're going to see very high white blood cell count. Again, in a person with ALL, right? You're going to have lots of lymphocytes, right? So I want you to make sure that you absolutely understand the 4 basic types. These are very basic types of leukemias, right? So I'm kind of jumping off a little bit off the PowerPoint for just a second, right? So you have lymphoid stem cells. If you go back to that picture, figure 9.2, and if you see that the lymphoid stem cell is going to make B cells and T cells. That's obvious, right? So if you have ALL, you have acute lymphocytic or lymphoblastic leukemia. That depends on which cell in particular you're going to see a lot of, right? ALL, again, very common among children, is from the line of cells that make B cells and T cells. If you have acute myelocytic leukemia, right, that's from the myeloid side. You might have a specific name for those. So you might see acute monocytic leukemia, okay? But notice that that still is the myeloid stem cell line, right? So I want you to make sure you understand that. So those are acute. Acute are going to come on suddenly. The chronic ones you might see recur throughout the lifetime. So chronic lymphocytic leukemia and chronic myelocytic leukemia. So those four you absolutely want to understand a little bit about the stem cell that it might be causing, okay? Again, that's not the only name you're going to hear. Oftentimes you're going to hear a name that is going to then tell you specifically what type of cell might be in high quantity. All right, so exactly, there you go. Myeloid lineage, right? Red blood cells, platelets, monocytes, granulocytes, and then that's basically all your white blood cells except lymphocytes, which are the lymphoid lineage. All right, so there you go. A nice review of figure 9.2, which is probably also found in chapter 11, obviously, right? And it is found on page 216. All right, so you can see there some of the cells that you might see, and then under B cells, notice you also have myeloma, right? Because myeloma are the B cell lymphomas. I'm sorry, the B cell cancers, right? So here you can see again, granulocytic leukemia is going to be granulocytes, monocytic leukemia, and then erythroid leukemia, you're going to see also called polycythemia, right? And then thrombocythemia, and also the megakaryocytic leukemia with lots of megakaryocytes, which make platelets. All right, so an example of neoplasms from the myeloid lineage include alterations in, right? So B cells, T cells, and natural killer cells are all lymphocytes. Okay, so again, hematologic neoplasms, acute myeloid leukemia, right? You might see also myeloproliferative diseases and myelodysplastic diseases. Right, and so the myeloid neoplasms are usually myeloid in origin. And then obviously the lymphoid ones are going to be B cell neoplasms, T cell, NK cell neoplasms, and Hodgkin's disease. Right, then you also have non-Hodgkin's lymphoma, which is much more serious than Hodgkin's lymphoma. Hodgkin's lymphoma does have a pretty good survival rate, right? So these are lymphomas of B cells, T cells, and NK cells, right? Very diverse group of malignancies, right? So the exact cause of a hematologic neoplasm is unknown. So that means that some gene along that pathway that makes cells in that cell cycle is going to be basically disrupted and losing control of differentiation and for cell division. So what are the possible causes? Remember, you're thinking this is something that's internal. So where you can see a cancer of the skin being caused by UV radiation because the light is hitting your skin, it might be harder to understand how that is introduced into the body. All right, so can these genetic changes be introduced? Viruses. Viruses are going to be one of the main reasons why genetic information is going to be modified, right? Radiation exposure, which can float through the blood, right? Chemical exposure, which again, you know, like lung cancer, since it's derived from something that is very toxic, like for the most part, right? Something very toxic like cigarette smoke. Well, it's not only all of those toxins are being inhaled, and even though the lung is the primary place, does not mean that some of those might not find their way into the blood and maybe cause some damage elsewhere. right? So a reduction or alteration in normal hematopoiesis. So remember, when the cell cycle occurs, there's always going to be a possibility that there's a mutation in a particular cell. This is always possible. It's not likely or happen very often, but it is possible. And then, of course, there's some genetic diseases that make you more, have a greater risk or more predisposed to developing some of these lymphoid neoplasms. And we're going to talk about some genetic components that are present in many people's genes that could put you at very high risk. All right, so some of the clinical manifestations are leukopenia. So I want you to notice that when you see the word penia at the end, that actually means low, right? And when you see something like leukocytosis, so the osis usually means high. So if you saw like, thrombocytopenia, then you mean, oh, okay, so their platelet level is low. Thrombocytosis, their platelet level is high. And so you might see erythroblastosis, right? So again, what does that mean? So that the cells, the erythroblasts, which are the cells before you have fully mature erythrocytes, are going to be in osis. So there's going to be many of them. So just think about and remember your medical terminology from week 1. All right, so lymphadenopathy, you might see joint swelling and pain, weight loss, anorexia, hepatomegaly, and splenomegaly. Remember, that means that those organs are enlarged. And these are all manifestations that you might see due to a low white blood cell count. Also anemia. So anemia meaning a low number of cells, and in this case, red blood cells, right? And then pallor, right, is a very characteristic occurrence because of anemia. So pallor means that you are pale in appearance. So you'll see that the patients will have very pale looking, especially around the eyes and the conjunctiva. You will see a very like pale or non-contrasting to the face, so they won't have rosy cheeks. They won't have anything that gives them or the appearance of color. So they look kind of Casper White. All right. Even if they have pigment, so you'll see pallor. Even if the person has darker pigmented skin, you will see that as a lack of that, like, dynamicism, where you might see those rosier cheeks and the eyes being kind of red and stuff like that. So you won't see that. So you got to kind of look for it in people who have darker skin. It's a little bit harder to miss, a little bit easier to miss, excuse me. Right? Fatigue, malaise, right? Shortness of breath, decreased activity tolerance. All of those things are definitely going to be from, as a consequence of anemia. I mean, shortness of breath, obviously you don't have a whole lot of oxygen. Decreased activity tolerance. With decrease in oxygen comes decrease in energy. All right. Thrombocytopenia, again, platelet count below normal. Because you have a low platelet count, then you're going to have these very characteristic red tiny dots called petechiae, because your blood vessels might be leaky. And that's because the platelet count is too low to really maintain or keep especially if there's a damage to the, not to the skin necessarily, but if there's like constriction to an area, then you might see some petechiae, very easy bruising, bleeding gums, and that obviously both of those are because the platelets. Remember, a bruise is simply a cut in a blood vessel that just doesn't open outside, right? So the blood accumulates in the tissue. So you'll see occult hematuria, right? So hematuria meaning blood in the urine, right? And then it might be like kind of hidden, right? And then retinal hemorrhages. So retinal hemorrhages, very common in people with thrombocytopenia. All right, sorry about that. I lost my slides, but I think I'm back. So hopefully we just continue right through. Okay, so So how do we diagnose some of these hematologic neoplasms, right? So other than, right, leukopenia, anemia, and thrombocytopenia, you might see neutropenia, which is a neutrophil count that's less than 500 cells per microliter, right? So some peripheral blood samples, and so we look at it under the slide, right, in the microscope, and that might actually appear like some of the pictures that are in your book where you're going to see lots of cells. Remember what you see in a particular slide. Okay, I don't have any pictures coming up. In a particular slide of red blood cells with white blood cells in it, you see a sea of red blood cells, and there's like a white blood cell. Because remember where there are, 4 to 6 million red blood cells, right, in a deciliter of blood, you're really only going to have about 10 to 20,000 white blood cells. So you're going to have one white blood cell in a sea of red blood cells. When you have a sea of white blood cells and red blood cells are kind of pushed off to the side, you know that that's definitely a problem. So they take blood samples, they might take bone marrow samples, and then they're looking for a difference in what they're expecting to see, all right? So then how do we treat these types of disorders, right? So the primary objective of chemotherapy is to remove the malignant cells, right? So basically you need to take the cell that is making this erroneous cell division and making many of a particular either myeloid or lymphoid cell line, and you need to stop it. So you give a chemotherapy drug that's going to stop that particular cell from dividing. Then once you've killed the bone marrow, right, because that's the target of your particular drug, because this is a leukemia, right, then you're going to perhaps try to rescue and restore the bone marrow. If that's possible, with the bone marrow that is already there, probably will require a bone marrow transplant, right? And then radiation and tissue-specific therapy may also be in conjunction with these two things that you're going to see. So I think I mentioned the same thing for autoimmunity. For autoimmunity, I know that you're not thinking an autoimmune disorder requires chemotherapy because it's not a cancer, but in reality, you have a cell that's making an erroneous antibody, and so the only way to stop that cell in autoimmune disorder from making that erroneous antibody, in cancer from growing, right, and undergoing mitosis many times over and over and over, the only way to do that without knowing the specific cell is to kill all of it. And I know chemotherapy very much is barbaric, in my opinion. However, we have targeted therapy is something that we are only getting to the beginning of, because we need to know what to target. So some people have, and I'm going to go over that, some people have a thing to target. And if there's a thing that is different in you, a gene, a protein that is different that we can target, then we can do that. But if it's not, then it has to be a bombardment. Yes? So chemotherapy, bone marrow transplant, maybe chemotherapy and radiation and bone marrow transplant. All right. So, right. Chemotherapy basically, as I mentioned last time, right, chemotherapy is partly going to kill that cell by inducing apoptosis, right? So that cell will go into apoptosis. You may also see somebody go into, right, complete remission and normal hematopoiesis and no detectable neoplastic cells after chemotherapy. But chemotherapy, right, it's not the only possibility, and complete remission is not a cure. So some treatments may include more than one cycle, right? And some, right, and then chemotherapeutic agents will be used to kind of induce the apoptosis throughout those different cycles. So you might see multiple cycles of chemotherapy, after which every cycle you're going to get tested to see what is the progress of this particular disorder. So again, depending on what they're looking for, if they're looking for, neutrophils, then, or granulocytes, right? So granulocytic leukemia, you're looking for granulocytes. How many granulocytes do you have? Is it back to normal? And then that is actually, promising if it does get back to normal, if the appearance is normal, if the bone marrow aspirate is normal, right? So again, it may induce remission, and so eliminating all neoplastic cells, right? And then post remission and consolidation is great to eliminate any undetected cells that may have escaped this induction phase, right? And then remission maintenance is to continue to stay in the state of remission as long as possible, hopefully reaching that kind of critical number, that 5-year mark. Again, the 5-year mark does not mean that at 5 years you're never getting the cancer again. I want you to know that it's more of a marker that epidemiologists use to indicate that you've been cured. But the reality is that even if you have reached 5 years, there's still a possibility of it coming back, right? So intermittent chemotherapy may be continued for 2 to 3 years after remission. And again, that is to protect the patient from having an exacerbation. So we want to keep them in remission. So if the CNS acts as a sanctuary for neoplastic cells, remember, a key thing that I mentioned before in the neoplastic chapter, chapter 7, chemotherapeutic agents cannot enter the brain through the blood because of the blood-brain barrier. So you might need to introduce a chemotherapy agent straight into the CSF, which is very high risk, right? And we call that the intrathecal route. All right. So one of the other main complications of your remission state, right, is maintaining, or and a chemotherapy state, when they're still in treatment, is maintaining an adequate nutrition. So, right, in a child, this may cause them to not grow to the height with which they may have grown without this type of treatment. So this treatment obviously is going to delay growth. It can cause anorexia, weight loss. Remember, chemotherapy is a bunch of chemicals that are going to attack a particular group of cells. They're toxic chemicals. So unfortunately, the reality is that chemotherapy is cancer causing. Okay. Again, chemotherapy is the only thing we have, because if we had other options are employed with or in lieu of, if they have very good results out of a lot of these studies. So if there's clinical studies and the result is very good for a particular cancer drug that is not a chemotherapeutic agent, it may be used without chemotherapy. But remember, you want to kill the cancer as quickly as possible. So Western medicine is just going to attack that particular cancer. And so you might see people having, remember, when you're receiving all these chemicals, you have a very chemical taste in your mouth. So I've heard that this is the main complaint, that things don't taste the same. So you have to be very conscious that people that are receiving chemotherapy are not tasting food the way that you taste food. Actually, I had a student of mine at West Coast give me a miracle fruit. So if you look up miracle fruit, Miracle Fruit actually changes and basically masks all of your other taste receptors in your mouth, and all you can taste is sweet. And Miracle Fruit is like sometimes the saving grace for a lot of these people who are in a place where they don't want to eat. Okay. And they get nauseous and they give up. Depends really on the combination of drugs. All right. So infection is also going to be, and so what we have to do is we have to manage these types of complications to try to minimize their effect. So, you know, as quickly and as early, right? These people are going to need a seasonal flu vaccine. They're going to need, right, to prevent as much as we can. They're going to get masks. They're going to get, you know, placed in a part of the hospital that is, you know, some negative air rooms and stuff like that, so that they don't get infections, especially when they have no white blood cells, right? So they need to be placed in isolation, right? Rapid management of these as quickly as possible, antibiotics, whatever is necessary. So again, many times these, you know, people with leukemias and anybody undergoing chemotherapy is going to be on a lot of medications. And then growth factors can also be used if they're neutropenic, so try to get the cells to start growing and making new cells, right? Bone marrow transplantation, right, to manage certain leukemias, right? If you have bone marrow failure because of chemotherapy, then we introduce new stem cells into the bone marrow and match it as closely as possible, right? Or graft versus host disease could occur, which is basically a type of rejection. We're going to talk a little bit about that. Peripheral stem cell transplantation, right, allows stem cells to be harvested from the circulating bloodstream and try to be reintroduced back into the bone marrow, right? So stem cells can be used from the patient's own blood, right? Just like we just mentioned, it's called an autologous transplantation. If you are using a matched relative, it's called allogenic. And then an allograft, right, is that actual tissue that's being used. So if it's bone marrow is a type of tissue, right? And then it can detect and kill the leukemic cells, right? So the graft hopefully will then detect and kill those cells. So you could see the difference here between the allogenic, using your own cells, right, and trying to counteract and reinfuse the bone marrow with some of these cells, and then the autologous, right, with the treatment, right, and then the recipient of that treatment will then basically follow the same process, right? So you can see here, right, conditioning, high dose cyclophosphamide, right? And then that is causing basically an entire radiation of the body. And so then we're ready for blood marrow transfusion, right? So very, very common complication of leukemia and chemotherapy is anemia, right? Normocytic, normochromic anemia, where basically you just have less red blood cells. And so we can administer erythropoietin type growth factors or RBC transfusion therapy to prevent bleeding episodes, so that we can get the cells up, because then obviously red blood cells carry oxygen, so you need that, right? Thrombocytopenia, you might see a platelet deficiency, even hemorrhages, because of the low amount of platelets. So you might see fresh frozen plasma being administered, or even pooled platelets, and that can really protect the patients from hemorrhaging after a trauma. And so obviously they will have restrictions in their activity, right? So pain obviously is a complication of many of these treatment protocols, right? Mostly involving the bones and joints, right? And infiltrative, like, accumulations of all of these neoplastic cells into the bone marrow causes pain in the bone marrow, which is in your end of the long bones. Hemarthrosis, you might see bleeding into the joints. And then mouth pain from stomatitis. It's very also common. So those sores. So stomatitis is the sores inside the mouth. So you can see that very common. And then the nausea that goes with it. Right. So pain management, right? You can have, narcotic and non-narcotic drugs, distraction, and biofeedback. So for a child, obviously distraction might work better. Unfortunately, they may still feel, obviously are still feeling pain. So distraction may or may not be helpful. But biofeedback is actually probably more so for an adult that can try to, it's almost sort of like a meditative state where you can get some sort of reply as to how your body is responding to you trying to increase or decrease the pain. So again, it's sort of a meditative state where you can have, like, say that if your heart rate's very high, you can get strapped onto a heart rate monitor, because a heart rate being high can happen with somebody who's in pain, especially if you're like screaming in pain, right? And so if you were to strap yourself to a heart rate machine, then you would try to sit there and look at the number and say, I'm going to lower that number. And so again, it's sort of meditative in state, but we have a physiological measurement of something that we can use. Like, again, heart rate is usually the best one. All right, so you can see epithelial cells obviously being affected, because remember that all fast dividing cells are going to be affected by chemotherapy. So this is why people lose their hair, because of the fast dividing cell. So the lining of their stomach is also a fast dividing cell. So the stomach becomes a little less tolerant of certain foods. So that does not help the nausea. And then abnormalities in growth development and fertility complications are all common complications of treatment, right? So some of the myeloid neoplasms, right, can result from transformation or proliferation of bone marrow cells, right? So it could be that, the offspring of an abnormal cell clones and builds up in the bone marrow and then are released into circulation, which is a little bit different than the actual cell itself just undergoing division, right? So then we call that myeloproliferative disease, right? So abnormal stem cell is multipotent, causing an overproduction of more than one type of cell. So then you might see that these cells are usually functional, and you might see a normal morphological appearance, a little bit different from the leukemias, right? So you can see chronic myeloid leukemia, and this is granulocytic, from the lymphomas, from the ALL with the lymphocytes. So these often do have functional cells. So then chronic myeloid leukemia, right, like granulocytes or polycythemia vera, which again I told you was the one for the red blood cells, right? And then essential thrombocytopenia, where you can see platelets in excess. All right, so usually discovered upon a complete blood count because the numbers are off, right? So very high numbers of certain cells, right? So involvement of that hematopoietic progenitor cell, which is that cell that makes those particular types of cells. That chart 9.2 that I've been alluding to so many times shows you what some of those progenitor cells are, right? So you have hypercellularity and overproduction of functional blood cells with sometimes chromosomal abnormalities, right? And then eventually they have conversion into things like AML or another fibrosis in the marrow. So you might see myelodysplastic, right, where they are morphologically and functionally abnormal. Prognosis of myelodysplastic cells, syndromes, are very poor, right? So very intense treatment is going to be necessary to extend life. And then chronic myeloid leukemia represents about 15% of cases of leukemia. In the United States, the average onset is 40 to 50 years and very rare in childhood and adolescence. One of these, this is the disorder that I was talking about that has this one really cool and very interesting, basically genetic abnormality. So you have the Philadelphia chromosome, which is going to be a translocation of chromosome. A piece of chromosome 22 gets chunked off, like they lost a sock on one of their, remember that it has the short arm and the long arm. So the long arm loses a chunk, so it looks like a sock. That's now gets added on to chromosome 9. And because you get this addition, and then chromosome 9 also has a chunk cut off and gets onto chromosome 22. So because they split and attach to each other, basically, right, you get a new protein product, right? So that new fusion gene, the BCR-ABL gene, now makes a protein, right, that causes this cell proliferation and reduces apoptotic cell death. Right, so there you go. The 9 to 22, right? You're gonna get the Philadelphia chromosome is called a translocation. So that translocation is basically going to mutate, and so the length of the chromosome is not really changed, right? So we're gonna take a piece of 22 and move it on to number 9, and then the piece of number 9 goes on to number 22 and makes this new fusion gene. Then that results in chronic myelogenous or myeloid leukemia. So this is a blood smear sample. You can see that there's an excess, right, of your granulocytic cells and monocytes in more than you would see. Remember I told you you have a sea of red blood cells, which are these, right? These are red blood cells. And then you have one white blood cell. And here you have like 7 or 10. All right. So CML cells have a greater degree of segmentation than AML cells, right? And so the clinical presentation is a very high granulocyte count in the CBC. And you have splenomegaly because there's so many, so large, that the spleen becomes a little overwhelmed. So you have fatigue, weight loss, sweats, bleeding, abnormal abdominal discomfort because of that enlarged spleen. Many times you probably have to have that spleen removed, right? It does not respond very well to chemotherapy. So untreated has a very low survival time of about 2 years, right? And then so basically acute myeloid leukemia is probably even worse with a prognosis of only 3 to 4 months. Right, so there is a drug, right? It's called amitinib, right? And this, anything that ends in nib is going to be a tyrosine kinase inhibitor, okay? And so they are basically, this medication, although it is quite useful in this anti-BCR-ABL therapy, it is very expensive, okay? Because I want you to understand the way the pharmacological industry works, right? Pharmacological industry and the pharmaceutical industry, right? How they function is they put in hundreds of thousands, if not millions of dollars into the study of a new drug. And so because they put in millions of dollars into studying a new drug, when the new drug is functional and it is approved by the FDA, they have a time in which that medication cannot go generic because they are trying to recover the costs of what they put in. I know that sounds really stinky, especially when you see like companies like Pfizer that really benefited off of Viagra, right? Which was not necessarily, oh my God, they did do a lot of testing on Viagra, but the function for Viagra was never, the intention was never for erectile dysfunction. The idea was it was going to help the contractility of the heart. And so in heart medication studies, they found that they had erections, and then all of a sudden, it became the gold mine, right? So yes, sometimes things happen in which the drug companies put in a little bit of money and make back a whole lot of money. But again, it's a corporation in the United States. And as a corporation in the United States, in a capitalist country, they are trying to make a buck. Let's be real, okay? In other countries in which medicine is universal and pharmaceutical companies don't have that, like, deal going on with the FDA, in which the FDA will not allow a generic to be made for at least 10 years after the discovery of a new drug, so that the pharmaceutical companies can make back the initial investment. You will find that in a lot of these countries, you do not have the same drive to find new medications, because again, finding that medication that like rocks the world is going to make the pharmaceutical company a lot of money. There may be companies out there that are doing it. There may be, universities that are getting funded through other ways of being able to do that. There are some rogue doctors out there testing all sorts of things. And the rest of the country in the United States is a very, very, in the United States, you have to take a lot of care with a lot of steps, with a lot of, you have to disclose everything that you're doing. So you're not going to get away being a rogue doctor for very long in the United States. But in other countries without the same type of regulations, they do whatever they want sometimes. And sometimes they hit upon something that really works. So, imatinib, also called Gleevec, was actually found in the United States. It was partially funded by the Leukemia Lymphoma Society, and very partially funded, by, the donations of people like yourselves. But unfortunately, it is still really expensive, on the order of about $5,000, a month. All right. So, then, right, treatment, another allogenic, right, bone marrow transplant, is also suitable treatment, right, or autogenic, but that one's less effective. So, the majority, right, of cases are, adults, right, with a median age of 64. And then malignant disorders, right, associated with the transformation of a myeloid stem cell. And so bone marrow aspirate must have greater than 20% blasts. Remember, blasts are baby or builder cells. They're the cells that are going to be before the final and mature cell. So when you see blasts, lymphoblasts or myeloblasts, you're going to see immature cells. So we have a lot of immature cells, and that's what you're looking for with AML, right? So, right, the FAB system is very commonly used for classification of these subtypes in AML. So most common is acute granulocytic leukemia, right? And that terminology, again, is very often interchangeable and interchangeably used with AML, right? So those have non-segmented nuclei, right? And very fine chromatin. So you'll see there very non-segmented nuclei. These are blasts, okay? So the blood smear sample, right? So you might see a genetic abnormality, especially if it's P53 or the RB tumor suppressor genes, right? You might see the 4, right, very common genetic abnormalities, either the translocation or some inversions. And then cytogenic class is not as apparent, but you might see some morphological transformations, right? The presentation of AML is very similar to ALL, very difficult to tell apart except for the clinical findings. You might see bone pain, anemia, thrombocytopenia, right, and increased susceptibility to infections. So very common sites of infection: skin, the GI, genital, urinary, and respiratory tracts, right? So AML, right, very abrupt onset of symptoms, right? Much worse prognosis for AML than ALL, right? So AML, less than 50% in children, and 30% of adults survive long term. Acute promyelocytic leukemia, however, is mostly curable with, right, but it only accounts for about 10 to 15% of AML subtypes. All right, so what is the treatment protocol incorporating, right? All of those leukemic cells, basically to individualized therapy, and monitoring responses. So basically trying to induce this remission. Okay, so prognosis and treatment, right? So even when remission is achieved, the patient almost always has a recurrence, right? Especially if they were only able to complete 1 or 2 cycles. So you might see 2 cycles to induce those 2 protocols, the ICE and the DAP protocols, to induce remission. Right, so you can see this is the Ann Arbor, or the what it mentioned here, the FAB system. Okay, so you might see it here. Acute myeloid leukemia, right? Involvement of a single lymph node, right? Stage 1, 2 or more lymph nodes, stage 2, lymph node regions, and to both sides of the diaphragm, right? And that's stage 3. Right, and then stage 4 is involvement of extranodal sites that are basically denoted by a plus sign, designated E. Right, so for stages 1 through 3, you have maybe an extranodal site contiguous or proximal to a known site, and for all stages, right, you can have a letter A, B, or X. Right, so A for no symptoms, B for some fever-like symptoms and sweats, and weight loss, and then bulky disease, which is a widening mediastinum. All right, so some of our lymphoid neoplasms, right, including malignancies, right, of B, T, and NK cells, right, leukemia when it's present in the blood, and lymphoma when it's located in the lymphoid tissues and lymphatic system, basically, and then right, lymphoid neoplasms, right, location specific, right, and then WHO classification. And remember, the WHO is the World Health Organization, and we usually say WHO, not WHO, but a lot of students will call it WHO, and it's kind of humorous. All right, so subcategories of B cell and T cell, NK groups, you'll see based on neoplastic cell maturity. Characterized cells for our precursor cells, right, are usually going to be stuck in that early blast stage, like I mentioned before. Remember that early immature stage. And then you might see mature cell neoplasms as well. Those are going to be more differentiated and often located in peripheral sites, so away from the bone marrow. And then CLL accounts for about 30% of all cases of leukemia in the United States. And you'll see that 95% are malignant B cell precursors. Right, so you might see asymptomatic at first, and usually found by accident, because they are probably having some symptoms that may be very non-specific, like malaise, or I don't have energy, I'm tired all the time, I'm fatigued all the time, that type of deal. And then they find chronic lymphoid leukemia, right? And so 5% are associated with a very aggressive T cell transformation type. All right, so symptomatic CLL, very fatigue, weight loss, anorexia, and then a lot of infections, right? And then malignant lymphocytes may be invading the bone marrow, disrupting the function, so you might see some enlarged lymph nodes and an enlarged spleen. Very common in the lymphoid tissues, because remember, in the spleen you have lots of lymphocytes, and in the lymph nodes you have lots of lymphocytes. Right, so bone marrow infiltrates, right? You might see red blood cells, platelets, and a preponderance of lymphoid tissues in that bone marrow, right? And then these are characterized defective apoptosis, and so they live long time because they are not undergoing apoptosis the way they should be. So they might be persisting very long in that bone marrow, making it kind of a little short on space in those bone marrow spaces. And then you might see also derived peripheral B cells, matured peripheral B cells. All right, so you can see a bone marrow aspirate example where you're going to have many cells. Remember that your bone marrow is going to look almost exactly like your blood, but you're going to see a lot more cells with nuclei, basically, right? Because there's a lot more cells that are going to be precursor cells. But see, there still is a lot of cells, red blood cells, that are fully mature. So, you might see genetic mutations present that may make the diagnosis either better or worse. And then chemotherapy is used to induce remission and stem cell transplantation to prolong remission. Acute lymphoblastic leukemia and lymphoma, right, is a malignant disorder of the lymphoid cell line, right? The 80% of the malignant transformation involves the B cells and only 20% involving T cells. Most abnormal cells are lymphoblasts, like they're looking like immature lymphocytes. Right, so you can see here an abundance of them. This is not normal. This is very abnormal. Remember, lymphocytes make up about 30%. These are also enlarged lymphocytes. So lymphoblastic, right, they appear and present as leukemia, but lymphomas are the same disease, just at a different stage. ALL is primarily a child's disorder. It is the most common malignancy in children. It is the second leading cause of death in children. So between 3 and 7 is the peak, and then the second peak of ALL is in middle age. So you'll see a lot of children, and when they do get, many times it is ALL. So abrupt and bone pain is a very important one. Very important symptom. Bruising, fever, infection. Children may have so much bone pain that they refuse to walk. They have a loss of appetite. They are fatigued and have abdominal pain because of that enlarged spleen or liver. Okay. 3% may also present with some CNS signs. 85% 5-year survival rate. I believe that's even higher now. So we might want to look. This book is from 2013. The new book has not come out yet. We've been expecting it for about a year, but it has not come out. And so that number, I believe, is probably higher now. 30% to 50% in adults, right? Basically, the chemotherapy that you can give children is very different than the chemotherapy that you can give adults, because adults have cells that have, been exposed to more things, and the toxicities are going to build up because they already have some toxicities because they drink alcohol or because they take medications like Tylenol and other things. So their liver might not be able to clean out things as well as a child's liver might because they're young. Okay, so they can be much more aggressive in children. So sometimes the children's protocol for some of these are going to be more intense than the adult protocol. Okay, so what they're saying is that the adults are going to receive a different type of therapy that might be intense, right? So monoclonal antibodies may be used in those that have particular tumors that are expressing certain antigens. All right, so which of the following leukemia presentations is primarily found in children? We've already gone over that. All right, so obviously B for acute lymphoblastic leukemia. Right, so some of the other leukemias, hairy cell leukemia, very rare, but chronic type of leukemia. So a lot of people will have this for a very long time. Only 2% median age of presentation, right, is going to be 55 years. Right, so they have these cells that look like they have hairs on them, right? So you can see that they are like wispies that come off of them. So that's why they're called hairy cell lymphoma. And you'll see splenomegaly in the majority of as a pathogenesis and manifestation. And then reduced number of granulocytes, platelets, and red blood cells. Treatment begins when the patient becomes symptomatic, enlarged spleen, or recurring in infections, bleeding disorders, anemias. Right, the remission rate is pretty high, about 80%, when following the proper chemotherapy protocol. Right? So plasma cell myeloma is also called multiple myeloma. It's basically a malignant disorder of mature antibody secreting B lymphocytes, which are also called plasma cells. It occurs almost exclusively in adults, usually 40 years of age or greater, about 65 years. So I want you to notice that many of these adult types of cancers are going to be the reason why cancer is going to be affecting so many people, and why it is the number 2 cause of death, because we are living longer than ever, and the longer we live, the more likely it is that we have accumulated sufficient exposure to viruses, sufficient genetic abnormalities, that we are going to have one of these manifestations. All right, so malignant plasma cells invading bone, right? And you might also see other tissues, including lymph nodes, the liver, spleen, and kidneys. Right? Abnormalities in chromosome structure number is commonly found in plasma cell myeloma, and malignant plasma cells may produce lots of monoclonal antibodies. Right? So they can be detected in the serum by something called electrophoresis, which basically is going to, it's like running a gel on a polarized fluid, and then if it's positive or negatively charged, it's going to move towards a particular pole faster, right? So like obviously the positively charged ones will move towards the negative pole. And so you might be able to see that, be able to separate some of those serum proteins. And then you might also see a large type of 1 antibody. So if you test the blood, a particular antibody is going to have very, very much in the bloodstream. Now, for multiple myeloma, we're looking for the Bence-Jones protein. That's the light chain antibody fragment that we are looking for in the accumulations in blood and urine. Helps pretty much confirm the diagnosis of multiple myeloma, right? And then it can accumulate in the kidneys, especially in the glomerulus, and damage them. Right, so you'll see then bone accumulations, and then basically destroying the bone, releasing the calcium into the bloodstream, causing a hypercalcemia. Right, so bone renal damage is a very common manifestation of multiple myeloma. Right, so what you're basically looking for is that antibody peak, Bence-Jones protein, hypercalcemia, and then bone lesions. So I want you absolutely to know that. Yes, so if any patient of yours comes in, they have hypercalcemia, Bence-Jones proteins, and an antibody peak, you're like multiple myeloma or plasma cell myeloma. All right, so bone marrow biopsy can confirm that diagnosis for you. All right, so you could see some of what the plasma cell myeloma is going to appear like underneath the microscope. Lots and lots and lots of cells. Very slow onset though. You're not going to see a very fast and acute onset of plasma cell myeloma. Right? So there's a pre-malignant stage in some people that they have these monoclonal antibodies but no bone lesions. And Bence-Jones proteins found. Right? In the urine. So we call that a monoclonal gammopathy of undetermined significance, MGUS. Right? So eventually, because these things are found in the urine, you might be diagnosed as having like a precancerous condition, and so eventually the majority of them progress to malignant disease. I'm sorry, not the majority. 25% progress to malignant disease, not the majority. So therefore, it is something to just watch rather than diagnose. Right? So you have like it's kind of like having a polyp. We're going to take the polyp, we're going to test the polyp, and then we're going to continue testing you for the next few years to see if that has progressed into malignant disease. Once we know that you might be at risk for malignant disease, then obviously it's incredibly important to see your doctor regularly so that if it does develop, we catch it as early as possible. Right? So Now the key thing with the multiple myeloma is that it can remain quite asymptomatic until it's very advanced. Right, so we're looking for our protein in urine, right, especially that Bence-Jones protein, and then the calcium levels being very high. And you might see bone marrow depression and anemia and recurrent infections and bleeding tendencies, and you also might see bone pain. Bone pain, very important. Renal insufficiency because of the Bence-Jones protein, hypercalcemia, and hyperuricemia, right? It's going to, and hyperproteinemia, it's going to result in end-stage renal disease. So you might see honeycombing effect appearance in the ribs because of the loss of bone, of the loss of calcium. So you could see some of that honeycombing examples in these x-rays. Right, so you're going to get some anti-neoplastic, right, to try to induce or maintain that plasma cell proliferation. And so you might see also chemotherapy regimens. It's not necessarily a gold standard that we use. It really depends. And then chemo followed by bone marrow transplants becoming very common. So autologous cell transplant is the best initial therapy, and then eventually, right, it might go into a full bone marrow transplant. And then pharmacological management and chronic bone pain might require some narcotics or non-narcotic pain relievers. Hodgkin disease represents about 30% of malignant lymphomas. Higher incidence in males, but it does kind of occur throughout the lifespan between 20 and 40 years of age. That's only about half. The 5-year survival rate for Hodgkin's disease is about 85%, so it's a very high rate of a high survival rate. Now, Hodgkin's disease is going to be characterized by these very large Reed-Sternberg cells that almost look like they have two nuclei. And so it really sets this type of disease apart from other lymphomas, and then basically is going to metastasize along the attached lymphatic pathways. All right, so you can see the contiguous pathways and the way that they might spread. Right, so you will find Epstein-Barr virus very much in the genome of the Reed-Sternberg cells. So apparently the presence of Epstein-Barr virus is an important pathogenesis in Hodgkin's disease. So you might see it in single node or a chain of nodes like the picture before. Reed-Sternberg cells often are accumulating within the node, and about 2% of these cells basically are in the lymph node tumor. So that's quite a high number. So you see that appearance again, like it looks like it has two nuclei. So it has two eyeballs looking at you. Okay. So rare lymphocyte predominance. The classic right, it could be divided up into 4 different subtypes depending on the cell in the tumor. Stage is really more relevant than histological pattern. Right, so origin of the site and dissemination stage is going to be really important as a clinical, right, a clinical management, right, of that disease, right? So you might see asymptomatic at first, and then some lymphadenopathy, night sweats, pruritus, which is itchiness, weight loss, and malaise as the time progresses, and then lymph node enlargements above the diaphragm, and then cervical nodes, the ones around your neck, are the most common. As you can see here, cervical lymphadenopathy of this patient. The nodes below the diaphragm are less common. Inguinal nodes might be most noticeable or mostly found in the inguinal nodes. And if the type of Hodgkin's disease is below the diaphragm, so subdiaphragmatic, disease spreads from the site of origin to other lymph node tissues, including the spleen and bone marrow. So that Ann Arbor staging system is also used for Hodgkin's disease, and so it has these 4 stages. And so the stage 1, right, you'll see is the involvement of a single lymph node, right, or of a single extra lymphatic site. Stage 2 is 2 lymph nodes along the same side of the diaphragm. And then stage 3 is going to be involvement of lymph nodes on both sides of the diaphragm, and so might also involve the spleen or other extranodal disease, right? And for Hodgkin's disease, right, it is limited to the upper abdomen, spleen, splenic hilar, the celiac or portohepatic nodes, or lower abdomen, and then disseminated for stage 4, so throughout, basically. Multifocal, so in many areas, involving 1 or more organs. So you have the liver, bone marrow, skin, with or without associated lymph node involvement, or isolated extra lymphatic disease with distant lymph node involvement, right? So prognosis, right? Absence of clinical symptoms in A, so B usually has symptoms at the time of staging, and might have also a loss of body weight, fevers, and night sweats that go along with that. CS is based on basically the history, physical examination, and then the PS is going to be determined by invasive procedure and invasive procedure results, excuse me. And then the basic stage is going to tell us how the treatment is going to go. So most commonly, if it's localized, you'll have radiation therapy, but if it's disseminated, it's chemotherapy. So which finding is associated with Hodgkin's disease? So remember the Philadelphia chromosome, the BCR-ABL, that's all chronic myelocytic leukemia. Bence-Jones proteins are for which one? All right, and then the Reed-Sternberg cells are for Hodgkin's disease. Right, so non-Hodgkin's lymphoma do not have the Reed-Sternberg cells present in the lymph nodes. 95% of B-cell, T-cell, or NK cell lymphoma occur in adults. And then you might see males at higher risk than females, most arising from the B cells, T cells, or NK cells, right? Prognosis varies much on the type. They may be quite aggressive, it's disseminated at presentation, and generally quite poor. And then as a group, they spread early and unpredictably when compared to Hodgkin's disease. So again, Hodgkin's disease has a pretty good prognosis. These B cell, T cell, and NK cell lymphomas do not. These are basically non-Hodgkin's type of diseases. All right, so similar to other malignancies, right? You're going to have viruses are suspected in the development of many of these, like Epstein-Barr virus, Burkitt's lymphoma, and then a 5-year survival rate of only 50%. Okay, so, right, most present with advanced disease, right? Manifestations, that is, there's very few, maybe very asymptomatic in the beginning. So you might see lymphadenopathies, fever, night sweats, weight loss, malaise. Extranodal involvement occurs quite early in your non-Hodgkin's, and so you might see infiltrative disease in the bone marrow or the bone in the GI tract. All right, so if you have complications, include superior vena cava obstruction and spinal cord compression. Those are going to be basically emergencies that need to be dealt with immediately. Complications including infections, bone metastasis, and joint effusions can be quite painful. And so the staging and classification is pretty much the same as the Hodgkin's disease, so keep that in mind. Right? So stage 1 and 2, favorable outcome. Stages 3 and 4, much less favorable. And therapeutic management is going to be different depending on the stage, the histological type, the patient age, and what their bone marrow looks like upon diagnosis. So radiation, chemotherapy, and tissue-specific therapies, including monoclonal antibodies if available, and bone marrow transplant. So you could see here a difference between comparison of acute lymphocytic, right, and acute non-lymphocytic leukemia, right? Right, ALL is very common in children. ANLL is common in adults. You have, hematologic studies are basically the same. You have the neutropenia, the anemia, and then thrombocytopenia. And then the cell morphology are going to be small to medium lymphoblasts in ALL, but very large, medium to large myeloblasts with clear chromatin and aerods. And then the cytochemistry is PAS positive for ALL, and then PAS negative for ANLL. You might see peroxidase positive and Sudan black B positive, some cytochemical markers that may indicate non-lymphocytic leukemia. All right, so that was chapter 11, and so I'll come back with chapter 13 for this week's screencast.